for a few people to come in from the waiting room, and we will start in a few moments. Perfect. So just a couple of more minutes and we will start. I hope you've all had a lovely day. You're all excited for this evening's talk. Okay, so I'm going to start the introduction and then we can get along with it. So my name's Natalie Watson. I'm one of the Laryngology Fellows at Guy's and St Thomas's. And welcome to the ENT Virtual Grand Rounds. Thank you, Ishan, for the invitation to introduce my current supervisor and mentor. Today's guest is Mr. Yakubu Karagama. He is one of the leading ENT surgeons in the UK. He leads the multidisciplinary specialist voice clinic at Guy's and St Thomas's NHS Trust in London. He has a specialist interest in airway, the professional voice, and dysphagia. He is at the frontier of promoting and developing new surgical techniques to help patients, and he's dedicated to helping patients. He is also a dedicated mentor and trainer. He is founder and course director for the Manchester and London phonosurgery courses. He has authored and co-authored over 50 publications and book chapters and is a council member of the British Laryngological Association, having been the first secretary of the association in 2011. So I just need to go through just a few housekeeping things if we go to the next slide. So please ensure that you are muted during the meeting. There will be a question and answer session at the end of the talk. Don't hesitate to put your questions in the chat or raise your hand and I will come and find you right at the end so you can ask your question. At the end of the talk, please do fill in the feedback form that you'll receive at the end of the webinar to generate your certificate of attendance. So I can't wait to hear Mr. Karagama's endoscopic management of dysphagia talk. So here is a virtual round of applause for Mr. Yakubu Karagama.
Thank you, Natalie, for the brilliant introduction for this talk this evening. And for the audience as well, we welcome you to yet again one of our numerous grand round. And I think some of you would have been following us and we go through different subspecialties. And even within the same subspecialty, we go through different topics. So far, I've covered quite a lot of topics regarding voice, airway, and dysphagia. And there are more to come, so keep an eye on that. So before I start, can I just check that you can see my first screen that says endoscopic management of dysphagia?
Yes, we can.
Right. So this topic is going to be based on my practice, based on what I do here. And also I'm going to show you some of the case studies that I've done as well. So dysphagia, I think one of the commonest causes of dysphagia is a high dysphagia. And when I say high dysphagia, it's around the cricopharyngeal area. You do get patients that have got dysphagia due to neurological conditions like weakness in the tongue base area and the follicular and the pharynx as well. But most of the ones that I come across as an ENT surgeon are the dysphagia that are related to cricopharynx. So you can see there is a very complex area of the upper esophagus, and this muscle can cause lots of problems, and i.e. can be a stricture, a web, a hypertrophy or spasm or a bar. It could be a pharyngeal pouch. You could have foreign body there in the pharynx and sometimes down in the esophagus as well. You can have neurological dysphagia causing swallowing difficulty at this level, or in the esophageal or in the oropharyngeal phase. You can even have functional dysphagia, inflammatory cases, neoplastic, iatrogenic, and post-operative cancer cases or post-radiation. So how do you diagnose these cases? The diagnoses are normally straightforward. First of all, it's just a good history taking and a very good endoscopic examination and evaluation of the patient's swallow in the clinic using either fiber optic nasal endoscopy or transnasal esophagoscopy. Sometimes you're going to need a barium swallow, video fluoroscopy. You may need CT scan and MRI scan. But really, CT scan and MRI scan mostly is to exclude other causes of the dysphagia. The barium swallow and video fluoroscopy does help us towards planning of treatment. Sometimes a physiological examination like pressure manometer may be required as well. So the surgical treatment that I use in my clinic are essentially transnasal flexible treatment or a rigid pharyngoscopy. For the flexible transnasal esophagoscopy treatment, I do that in the office under local anesthetic spray to the nasal cavities and the pharynx. And for the rigid pharyngoscopy, it will require a general anesthetic. So all of these procedures that you can see listed here can be done either in the office or in the operating room, depending on the patient selection. And when I say patient selection, whether the patient is suitable and whether the patient will agree to have it done under local anesthetic, or they might prefer to have it done under a general anesthesia. So I'm going to start with the office balloon dilatation via the transnasal esophagoscopy under local anesthetic. I'm going to give you one example of some of the type of patients that I receive. Now, this history I've given here is of a real patient, but the picture on the bottom right there, it's not the patient on this history, because I wouldn't like to put a patient's picture like that with their history. But I've seen patients like this presenting with this kind of symptoms. So when I say a patient like this, it means patient with significant comorbidity and patients with obesity. They will come to you, they will say either they cannot swallow at all or they have discomfort when they swallow. I think all of these patients should be taken serious, especially some of these patients that will come to you and say they can swallow, but it's hard to swallow. And I'm going to give you one example as you're behind your screen now. If you can just do me one favor and just put your finger in your neck like that. Just 2 fingers, all of you, please. I can see a couple of you are not doing that. Yeah, that chap from Spain. Yeah, and you from, yeah, everyone. Yeah, I can see all of you are doing it now. Everybody is doing it now. So try swallowing your saliva. Yeah. So it's not comfortable. I can see some of you are struggling to do that. Now, if you are to be having this kind of feeling each time you have a mouthful, it's not comfortable, because eating sometimes is a pleasure. Sometimes we eat eating not just for nourishing. We go for meals, for socializing, and you want it to be a very nice experience for you. And this is why these patients, some of them, they're not losing weight. Some of them actually, they're adding weight. One of the reasons why some of these patients will be adding weight, they will be obese, is because they only rely on soft diet, and most of the soft diet is just full of sugar. So when they come to you with sensation of difficulty in swallowing, don't discard them. Don't start to judge them because you consider that they're not losing weight, so what's the problem? Because this patient are not going to go away. So thankfully, we have this in the available. When I say that, it's the transnasal esophagoscopy. We can use this to examine patients thoroughly. We can use this to manage some of these patients that don't have a very severe dysphagia, and we can manage them easily in the clinic. So a TNO, a transnasal esophagoscopy, is really an elongated fiber optic nasal endoscope. So it is 60 centimeter long, about 5 millimeter in diameter, and it has a working channel as well, 2 millimeter. So through this channel, you can pass a guide wire for the balloon dilatation. You can pass a biopsy forceps. You can pass a laser fiber. So if you look at the picture here, a third of patients that present with pharyngeal dysphagia would have a distal cause. Now, why is that? This is because the vagus nerve supplies the top of the esophagus, pharynx, and the gastroesophageal junction as well. So this patient will have a referred pain. And this is why sometimes when you have patients with otalgia, with no physical signs in the ear, you do scan of their neck, and some of them may have pharyngeal cancer. And equally, you may have patients with gastroesophageal junction tumor that will present with dysphagia, or they may have pain in the pharynx. Now, why am I telling you this? I'm saying this because I want to highlight the importance of doing a transnasal esophagoscopy in patients that present with a high dysphagia, because I've seen cases whereby they came to my clinic with high dysphagia and I found that they have gastroesophageal cancer. I think it's a blessing that we have this TNO available and we should make the most out of it, because lots of the gastroenterologists will tell you, or the upper GI surgeon will tell you that esophageal cancer present late. And the reason it present late is because some of the symptoms they present with early would be just minor symptoms that could have been picked up easily if we use TNO on these patients. So what does TNO enables us to see? With the TNO, you can examine the whole of the upper aerodigestive tract, so the nasal cavity, the pharynx, the larynx, the esophagus, the stomach, and you can also come back again and then examine the whole of the trachea. You can examine the bronchus, the terminal bronchus, all at just one sitting. And all you need to do really is just to anesthetize the nasal cavities and the vocal cords, and bingo, you're ready to examine the whole of the upper aerodigestive tract. This will save you from multiple referral to patients. And also when you refer these patients, say, assuming you found something in the esophagus or in the trachea or bronchus, at least you will send a positive diagnosis to the appropriate specialist. This is another patient that presents with dysphagia. So you can see that this patient has got a thrush in the pharynx, but actually there's a lot in the esophagus as well. Now, if you don't do the TNO, you won't be able to see that. This is the patient just 2 weeks after treatment with fluconazole. So this patient has also got right vocal cord paralysis, but you can see the esophagus is nice and clean now from that. Another example is this patient. So this patient presented to my clinic with dysphagia. When you look at it, it looks clean, like there's nothing there. But when I do TNO on these patients, it's completely different picture that I could see there. So you can see the esophagus is full of thrush. Now, if I didn't do the transnasal esophagoscopy, I wouldn't be able to find this thrush that is causing this dysphagia. So my next talk is going to be on the balloon dilatation. So I use a Cook Medical balloon dilatation, but there are other balloons as well, like the Boston dilators. So with this patient here, so this is one of my patients that presented with cricopharyngeal bar. So you can see on the picture on the left side, the barium swallow there showing a significant cricopharyngeal bar. So a cricopharyngeal bar is just a protrusion of the cricopharynx. This may be due to hypertrophy or scar or fibrosis there. So you can see half of the esophageal inlet is being taken over by the cricopharyngeal bar. So I'm just going to play the video for you. This is a complete TNO performed in the office under local anesthetic. So I spread the patient nose with cofenalkine, which is a 5% lidocaine with phenylephrine, and then spray the pharynx as well and the vocal cords as well, just to prevent the patient having the choking sensation. Oh, there is lots of secretion there. I think that's what's making me cough. See that? That's quick. So that is the esophagus there. Just esophageal junction. and down into the stomach. So now this is a retrograde examination of the gastroesophageal junction. So there are two ways you can introduce the balloon. You can pass it through the same or the opposite nostril, or you can use the guide wire that passes through the channel, and then take the guide wire, take your scope out, and then pass the balloon over the guide wire. So this is the balloon going through the postnasal space, and on the direct view into the cracopharynx. So the whole procedure will be just under half an hour. So I use size 20 millimeter inflation, and the balloon stays there for 1 minute, and then we take it out.
Well done. Well done. Score of 0, no pain, and 10, the most severe pain. Like 0 to 10.
Well, in the nose part, it was, it got a bit painful because it's pressing against the bone.
Okay.
Yeah, and so that was about 5. Yeah.
Or 5, yeah.
And down here occasionally it got to 5, but not for long.
Not for long.
No.
What about here in the throat, when the pressure was off?
Yeah, that was about 3 or 4.
About 3. So here I'm just assessing his pain. So I normally score all patients whether they have pain or discomfort from 0 to 10 in the nose and in the throat, and sometimes in the stomach. The reason why they may have pain in the stomach sometimes is when you inflate the stomach, then the gas can give some pain. Then in such cases, you will need to aspirate. And during the balloon dilatation, they will have the pain or discomfort for 1 hour, for 1 minute during the stretching of the cracopharynx. Some patients may have some pain in the nostril as well. But now I'm using like Instijet, just like a KY jelly with lidocaine in the nasal cavity to reduce the pain as well. After 30 minutes, you can eat and drink. Yeah. Because your throat will be a bit numb. Yeah, with the coffee, yeah. So in half an hour. So it's 9:45 now. So at about 20 past 10, you can have something to eat or drink. Okay. But this is your appointment. I will see you back in a couple of months. Okay. Hand it over on your way out. Thank you very much. Yeah, you're most welcome. Take care. Bye-bye. So traditionally, in the past, we would have admitted this patient, give them a general anesthetic, do this procedure, and then they may stay another night in the hospital. But this business with the TNO, the whole thing is just rounded up within just half an hour, and the patient is gone. This is another patient. It's a 55-year-old gentleman with who had pharyngolaryngectomy and radial forearm flap, followed by radiotherapy. So you can see this patient has got a stricture there in the upper esophagus. So I'm just going to play the video for you with the balloon dilatation. So this is just a speech valve there, you can see. And this is the balloon. This has been deflected. So you can see it's twice the size. So most of this dilatation, in some cases, we only need to do it once. There are patients that we may need to repeat it 6 months or 12 months down the line. Every patient is different in these cases. This is a patient that complained about pooling of saliva in her throat, chronic cough, and sensation of lump. And you can see why she's having that is because she's got like some narrowing in the cracopharynx as well. And she was fine after the balloon dilatation. So this is a guide wire going through the TNO. And that's the balloon there stretching. Again, it's all under local anesthetic. It's all done. This particular patient has got a stricture. You can see that. It's quite a very long stricture there. And this was following chemoradiotherapy for squamous cell carcinoma for larynx, in the larynx about 5 years previously. So the patient had dysphagia to both solid and liquid. So you can see the guide wire there, and then the balloon in there now. So you've seen different case presentations here, the cricopharyngeal bar, post-radiotherapy, post-surgical removal of a tumor. This can all benefit from your TNO. So this is me irrigating the wound area just to check that there's no perforation. There's a small mucosal tear there because it was a very tight structure there. Again, this is another patient with cricopharyngeal bar. With this patient, I had to repeat his procedure a couple of times. So the second time the patient came, I had to use double balloon, and I had to do that under sedation because it is very painful with the sedation. Now, why would I be using double balloon? The reason is because the cricopharynx is not a circular opening. It's like a kidney shape. This has been demonstrated by my very good friend Peter Belewski from Sacramento, where he put the balloon in a cadaveric pharynx and then did an X-ray with a barium, and it shows that it's actually a kidney shape. So this is where some of these patients will benefit from double dilatation at the same time, because if you just use one, it may just be one part of the cricopharynx that is dilated. What about foreign body? Can we check a foreign body through the TNO? Yes, we can do that. So this is a patient that's presented with history of food stuck in the throat. And this is what we found. So she was eating chicken, and she had dysphagia from that. So you can see lower down here, this is the foreign body there. So if you're going to use TNO for that, you can inflate it and it drops in the gastroesophageal junction. So you can see in this patient, there is a lesion there. So you see that lesion there. So I took a biopsy from that. And then I push the meat into the stomach. But first of all, I sort of tried to pull it out if I could, but that didn't work. And if you're going to pull it out, you might have to take it out through the mouth. So you can see the meat in the stomach. There it is. So we're sure that it's gone to its final destination safely. And that's a biopsy I'm taking from the gastroesophageal junction there. Again, fish bone, you can easily take that using the TNO. So that's a forceps going into the TNO to take this fish bone. This patient was going to go to the theater for this minor procedure, but I managed to intercept this patient and took the patient to the office and then removed the fish bone. So it's a very soft bone, just easily took it out through the nose. Just like that. Right. What about general anesthetic? Because if you don't have facilities for doing this on the local anesthetic, yes, you can do that on the general anesthetic. The view is quite good, but sometimes esophagoscopy can be a problem on with the rigid scope because the light source may not be great enough. So this is a patient with hypertrophy of the cricopharynx, as you can see there. So although it is nice opening there, but there's a very huge bulky cricopharyngeal muscle, usually is due to laryngopharyngeal reflux. So in this patient, just using one balloon is not sufficient. So you can see I've put one balloon and there's still some space there. So I use two balloons. So this is two balloons size 18 each. So I've stretched it up to 36 millimeter. So it's remarkable how elastic this area is. The maximum I've stretched in the past was 40. So you can see just small mucosal tear there, but otherwise it's nicely widely open. I've also injected Botox in this patient because it's quite a significant hypertrophy there and spasm. This patient has got cricopharyngeal spasm, from the history and barium swallow as well. So I'm using balloon there. It's under general anesthetic. This is a single balloon I'm using for that. And it is a 20 millimeter balloon, and I inflate it with normal saline because sometimes the balloon can burst and the water or the saline can go into the trachea. But if it is just 20 mils of normal saline, it is absolutely safe. So you leave it there for 60 seconds. And then deflate it. It all comes out. Just like that. Now, this next case is it was a very challenging and interesting case. She was an 82-year-old lady with inclusion body myositis. Now, this is a condition whereby the patient's antibodies damages some of the muscle fibers. So this patient developed dysphagia, and she was inserted with a peg, and the peg fell out, and the gastro team couldn't put the peg back because there's just no entrance at all to the esophagus. So this patient has got total dysphagia, as you can see there. And the only option the patient had was an open gastrostomy, but she's not well enough for that. So under general anesthetic, I performed a pharyngoscopy. You can see I'm trying to find where the opening is. There's no opening at all. It's completely sealed. So you see the balloon is not going in there. So I had to use a blunt instrument like a cup faucet to gently tease the mucosa in there. As you can see it there, just coming out. And I was able to find a very small lumen there. This is the patient's barium swallow beforehand. I'm just trying to illustrate to you how completely blocked it is. There's no dye going down at all. So I have to put a bit of pressure there and then insert it. Another way you can do this is by doing it jointly with the gastroenterologist or the OPAS GI, whereby you can pass the guide wire or the camera through the peg tube from below, and then you can meet up somewhere halfway. So with this patient, I used double balloon there because I want to get the maximum dilatation there. And this is the second balloon going in, and then you inflate the two balloons all simultaneously. You can see one inflated. And there's the second balloon. This is two 15 millimeter balloons, so up to 30. Stretch it. And it's always good to have a look further down into the esophagus because sometimes this patient may have more than one stricture. So in this case, luckily, it's just one stricture in the cricopharyngeal level. So I'm just using the CNO to have a look inside. So this is the esophagus there. And that's the stomach there. And this is the patient 4 weeks later. And you can see the cricopharynx healed nicely. There's the esophagus there. And then she was so pleased, this lady, she actually wrote her story on the newspaper, on the Daily Mail. So some of you would have this old bougie in the theater. Do not throw them away, please, because even though we have this balloon dilatation, there are times whereby the bougie may become handy and useful. And I will show you one example. So this was a patient with total dysphagia following chemoradiotherapy for neck node and neck metastasis. And she had peg tube for a year, and she did not like this peg at all. And she, despite the peg tube, she was losing weight, she's not nourished at all. And she asked me if I can stretch. And you can see I tried to stretch on the GA, it's completely blocked. There's a stricture at 15 centimeter, nothing there. So I managed to perforate this membrane there. This is just the anesthetic bougie I used. And I thought, oh, that's fine. It's a straightforward one. but this patient has multiple stricture. So there was another stricture at 20 centimeters. And I said, okay, this should be the last stricture I'm gonna have now. After this, we should have a nice, clear passage. There couldn't be possible more than, and then there was another one at 25. And so, okay, what's going on here? And another adhesion at 30 centimeter, and then a stricture at 35. So the whole of the esophagus actually is almost completely closed. Anyway, so step by step, I managed to stretch it and dilate it. With this patient, it should be impossible to do a joint double approach from below, because if you go through the stomach, there are multiple structures, so you're not gonna meet up anywhere at all. So this is, you can see the PEG tube from inside there. And this is the patient just a few weeks post-op. So I've passed nasogastric tube just to be sure that I've kept it patent. And this is it. So the patient is eating and drinking fine. The reason I put the nasogastric tube is just so that it doesn't close back and I will be able to stretch if needed. So and 6 months later, I saw this patient in the clinic for her follow-up. And she said to me, oh, you saved my life. And I said, how did I save your life? I haven't said you saved your life, because you had cancer, you had surgery, that saved your life. And she said to me, she was going to take her life if she's not able to eat by mouth, because at her age, she feels like life is not worth living if she can't go out with her family, she can eat what she wants, and all just feeding through the tube, everything is just worthless. And that was what she meant by this procedure, that it saved her life. This is another patient again, and this is again the importance of making sure that we don't just rely on the PEG tube. This patient may need examination of the upper esophagus. So this patient had total dysphagia after radiotherapy for supraglottic tumor 12 months earlier. And she didn't like the PEG tube at all. Everyone kept saying to her, well, you're getting your nourishment, what's the problem here? But she doesn't like to be living on just the PEG tube, because again, same thing, she doesn't feel like life is worth living. So I managed to gently tease the adhesion, stretched it. But the most interesting thing on this patient was that she had a synchronous tumor at the upper esophagus. So I'm using double balloon here. The reason I use double balloon is to be 100% sure that I've stretched it maximally. So this is this patient, and I had a look further down, and you will see here in a moment, there's a tumor there. So there's a small cancer growing there. And if not because I've looked and dilated and stretched, this patient wouldn't have been able to be diagnosed with this tumor there. Now, so that is it. This is about balloon dilatation. The next step is going to be endoscopic CO2 laser cracopharyngeal myotomy. This is my approach for treating pharyngeal pouch. I've changed over from using staple device because sometimes the staple device may fail to clip, but also if it's a small pouch, it's difficult to cut the fiber. And until you cut up to 90% of the fiber, the patient will still have dysphagia. So this is a patient of mine. You can see the barium swallow there showing this pharyngeal pouch. So this is just an illustration of my approach for CO2 laser pharyngeal pouch division of cracopharyngeal muscle. So that's the Killian dehiscent area. You can see the pouch over there, and this is the muscle that I'm going to be cutting. And this is the barium swallow of this patient pre-op. So it is quite a large pouch. Often people said, well, it's a large pouch. How can it help if you just cut the muscle? What you seem to forget is that it's not the pouch that is causing the dysphagia. It's a cracopharyngeal muscle that is causing this dysphagia. If you go and take the pouch and leave the muscle, the patient will have dysphagia still. So the key really is to address the muscle. So this is a cracopharyngeal muscle there. I use laser set at 1 watt at high magnification of the microscope and cut through almost all the muscle fiber. If you're concerned that you cause perforation, you can put a stitch there as well. So when you put it at high magnification, you can see all the muscles are gone. There's just a bit of fascia there and fat there, but we've not gone through and through. So I normally put nasogastric tube because sometimes the first day they may have pain swallowing. And if you're not sure whether, or if there's a doubt that you may have perforation, at least you've got the nasogastric tube there, then you can do a control swallow to check that. And it's always good to check the posterior blade of your diverticulum, because sometimes you can, if you force it too much, you may have a perforation at the posterior pharyngeal wall there. So very important to examine this area after you've removed the via diverticulum, as in this case there. This is another patient. This is quite a large pouch. It is very important that we examine inside the pouch, because sometimes you may have squamous cell carcinoma developing in the pouch. One of my head and neck colleagues here just operated on a patient a few months ago with a squamous cell carcinoma within a pharyngeal pouch. So this is the pouch there. And sometimes we may find so many different things. 2 weeks ago, I was doing a pouch surgery. We found a piece of onion in the pouch. So we have to retrieve it, because you don't want the patient aspirating that later. So you can see the muscle fiber giving way. So you have to be doing it under high macroscopic examination and magnification. There was a patient that I was doing, and there was a big blood vessel underneath that. I know one of my colleagues, Mark Watson, had a patient whereby there was an innominate artery below the muscle there. And in such cases, you have to stop. So always have suction monopolar diathermy handy as well, because you may experience some bleeding there. In such cases, you need to use the diathermy to stop the bleeding. So you can see most of the muscles are gone. And because it's a very low power laser, there's no even charcoal forming there. It's just cutting neatly. Like that. So you can see, so you have to be careful posteriorly, because the pouch is folding over the esophagus posteriorly there. But if you have a small hole there, it's not the end of the wall. As long as you recognize that, you can put stitch there to close it. So this is what it looks like post-operatively. You can see most of the fibers are all gone. And normally I give the patient water, just sterile water overnight. And if there's no problem, I feed the patient the next day. Because if there is any perforation, I want to know straight away, because I don't want the patient to go home and then 6 days or 5 days later, you find that the patient is having, has had perforation, and they will come back with mediastinitis. The endoscopic stapling looks like that. So you can see how you can staple that. Some people still use it. Fine if it works for you, but I use the laser. So in conclusion, patient selection is the key. And then there's a learning curve for these procedures as well. But some of these procedures, when you do them in the office, it saves time and money as well, and less morbidity with these patients when you do them endoscopically. So as Natalie said, I run courses on laser, laryngeal airway, phonosurgery, transnasal oesophagus courses. And these courses are fresh, frozen cadaver dissection courses, and places are limited. We had to cancel it last year because of the COVID pandemic, but hopefully soon we're going to resume once things have got better worldwide. Thank you very much, everyone.
Thank you very much, Yakubu. Mr. Karagama, that's amazing. It's a really great whistle-stop tour of dysphagia, and I can tell you firsthand, it absolutely works for our patients. So we're very, very pleased and proud to have you at Guy's and St Thomas's. So we've got quite a number of questions. So I'm just going to go through them one by one. I think it's going to be beneficial for everybody. So firstly, the first question was from Syed Hassan, who's got 3 questions here. Is the endoscopic evaluation done by rigid or flexible scope? Now, I know that there was a video of that, but I'll let you answer that.
So what is his question?
So the question is, when you do the endoscopic evaluation, I suspect under general anaesthetic, I think, are you using just the rigid or are you using the flexible scope?
I use the flexible scope, the transnasal esophagoscopy. So this is one video there. So this is the patient sitting up in the clinic, and I'll show you another. Let's see if I've got another picture again that I've hit in there. I may not get it here.
So I know in the clinic you use a transnasal esophagoscope, and on the general anaesthetic you do a rigid esophagoscope, or you suspend a pharyngoscope and then can use the flexible scope to go through. Once it's all suspended and you know the entrance, you go with a transnasal esophagoscopy.
Yeah, you can do that as well, but usually if I am to assess under general anaesthetic, I use the rigid scope throughout, the long esophagoscopy, and you can put a telescope through that as well. There's not huge advantages using a flexible over the rigid. I think that patient I showed you earlier with myositis, and it's mainly because with an intention, that possibility that I may use the TNO for other purposes while I'm there as well. But actually, if you're going to go for rigid, most of the time, you just do the rigid under general anesthetic because you have different length of the esophagoscope, and I can pass the long esophagoscope right into the stomach, although risk of complication is higher, and the complication can be fatal as well if you perforate in the chest level.
Fantastic, thank you. There is a second question from Saeed. He's asking, what's the ideal treatment for the fungal involvement of the pharynx and esophagus, and how long do you treat it?
I give them fluconazole, depending on their body weight, either 50 milligrams if it's a small person for 2 weeks, or if it's a large person, I give them 100 milligrams for 2 weeks.
And I think just sometimes if you've got any liver failure as well, you just need to...
Yeah. There's nystatin as well as an option. So if you're worried about liver failure or liver function, then you can use the nystatin 100,000 international unit 4 times a day for 2 weeks.
Perfect.
And then review the patient. Some of the patients may have recurrent obstruction, they have like underlying comorbidity like diabetes, or if they're on immunosuppressive medication.
Now we have another question about can TNO be done without sedation?
I do all of my TNO on the local anesthetic spray and not with sedation at all. I've never used sedation when I do TNO. So it's all in my clinic, and I do that with local anesthetic spray and then a xylocaine spray to the pharynx, just like you're passing nasogastric tube.
Yeah. And it works very well. It's tolerated really well.
Yeah.
So there's been a few questions about esophageal tears. And for example, if you're in the clinic with a transnasal esophagoscopy and balloon dilatation under local, how do you proceed with managing a patient with a mucosal tear?
So if it's a mucosal tear, don't do anything. It will just heal by itself. I would be surprised if you're able to perforate in the clinic under local anesthetic, because the patient will have so much pain that the patient will not let you proceed. Yeah. So I think the reason why we have tear in the general anesthetic is because the patient is asleep and we overstretch. You keep stretching like there's no end of the wall there. But under local anesthetic, you will not perforate with the stretching. You could perforate if you force the TNO in there when you're doing the TNO. But even that, the patient will stop you.
And it's a higher chance if there's a pharyngeal pouch.
Yeah.
Okay, so the next question is more about complications. What happens and what do you do if a balloon bursts when you're dilating in the clinic?
Maybe I shall allow you to answer that, Natalie. But if the balloon bursts, it's just normal saline. Usually, you'll just hear the pop. And the patient will cough and swallow the water. It's just normal saline. You don't do anything. Just get a new balloon.
And so that was one of the first things that you taught me, was that the most important thing is not to inflate with air, not to inflate with water, but to inflate with normal saline, so that if it does burst and you aspirate it into the lungs, then at least it's better for the patient than if it's water.
Yeah, because it's just 20 mils of normal saline that is in that. And if it bursts, maybe 5 mils will get into the trachea. But the patient's vocal cord, because of that reflex thing, they will stop it, and then the rest, the patient will just swallow it. Yeah, it's unusual for it to burst unless there's a fault on the balloon, or if you overinflate, because you need to inflate maximum 6 atmospheric pressure. If you look at the labels there on the balloon itself, it tells you the maximum stretching. But if you get carried away and keep inflating, then it will burst.
Now, the question was, how do you manage such a complication? Essentially, it's
with the mucosal tear.
The balloon bursting.
Or the balloon burst, nothing happens. It looks pristine clean there when it bursts. So the patient will swallow, cough a bit, and get a new balloon, because it doesn't leave any damage there.
Now, the next question is, other than double balloon dilatation, would you consider GA, general anesthetic, as the first line in any other situations? And is there anything to preclude you from trying a TNO first?
So we're talking about patient selection here, and whether to do it in the office or in the theater, and what makes me decide to do that in the office or rather in the theater. So most of the patients, if there is a reasonable lumen there, I will offer them a local anesthetic. But if the patient has got a total dysphagia, or if it's just like a pinhole, like they have got a peg, nothing is going from the top, I will go for a general anesthetic.
Now, they're just asking you about the SuperPulse continuous laser settings. What do you use for your cricopharyngeal myotomy?
So I use CO2 laser, SuperPulse continuous, usually at 1 watt. I have a scanner laser, but if you don't have the scanner, the spots, it will do the same job as well. The advantage with the scanner is there's less scar formation there. So on vocal cords, they're very good. But for the cricopharyngeal myotomy, I use a very small low energy, because I don't want to use too high energy on the laser so that not to create perforation.
Okay, we've got some questions specifically about pathology here. What are your thoughts about keratoacanthosis and of salmon patches?
Keratoacanthosis and some patches. I think some of this you have to take a biopsy to be sure that this is what you're seeing. And because you may find that actually they may have some dysplasia, or they may have some chronic inflammation there, or they may have eosinophilic esophagitis. So if I see some changes, any changes I see there, I take a biopsy.
How often have you had to revise your endoscopic pouch surgery, if at all?
With the CO2 laser, I've not had a single patient that have come back for a revision. However, I know one will come one day. I've not done 100 yet, because the revision rate could be up to 3% or more in some cases. So I'm not saying that it's not going to happen, but I'm pretty sure, I'm hope it doesn't happen, but it's going to happen. But I've done quite a significant numbers of them and no recurrence.
Okay, there's a question about ingestion of button batteries, and after removal, you found a burn and possible perforation. How do you manage it?
Depends on where the perforation is. If it is lower in the thoracic esophagus, I will have to manage it with the cardiothoracic team. I will normally pass in the gastric tube, give them antibiotics and anti-reflux medication. They may or may not require steroids. Steroids is probably less helpful unless if the airway is affected as well. If it is higher up in the pharynx, again, I will use a gastric tube just to allow the air to heal, anti-reflux medication and antibiotics. And then wait for the granulation to settle down. It may heal and stop completely. It may have a perforation there, or a fistula even in some cases, in which case, again, if it is higher up, you can close it up, but if it is lower in the chest, this is a case that you have to manage with the upper GI doctors and the cardiothoracics.
And of course, if it's, I've had this with children, ped surgery as well.
Yeah.
So we've got some more questions here. So a question about pressure manometry in which patient cohorts are you thinking about manometry testing?
First of all, manometry testing, there is two schools of thought on it. One will say you need them in all of these patients that you are querying upper esophageal narrowing, like say spasm, or some kind of dysfunction. One school of thought said, well, it doesn't change your management for anything at all. Some people say it's academic. It's not readily available a lot. I don't think it's something that ENT rely much on. But the gastroenterologists, they use it a lot because they measure the rest of the esophagus with it as well, and they assess it as well. So for me, it's not something that I use a lot. So, and maybe I should be using it a lot. I don't know. I am open about it, and I'm hoping that I'm going to find somebody that uses it a lot, that I can learn some more with the manometer from that person.
We have a really good question. Is the balloon to the cricopharyngeus helpful if there's just cricopharyngeal spasm and no stricture?
Yes. The reason is because spasm really, to diagnose it is not easy. And one of the reasons why I diagnose patients with spasm is because often when you do the barium swallow, the radiologist will say it's normal. And when I look critically, some of the views, you may find actually there is some indentation. And these patients, they can swallow, but they have this sensation of obstruction each time. And when I stretch them, they feel better. The options also is Botox injection for this patient. You can inject Botox in the office or in the operating room. The downside of Botox in the office is if you don't do many of them, you can easily inject into the posterior cricothyroid muscle. And again, you cannot inject big doses as well. So general anesthetic probably is more precise, but again, there's a morbidity with the general anesthesia. And sometimes you may think it's just spasm, and if you inject Botox, it may not work because it may just be some fibrosis in the muscle. But if you use the balloon, at least it's going to just stretch the whole thing. Plus, with the Botox, you're going to have to repeat it after a few months, in some cases, because it wears off after 3 months. With the balloon, not quite often you need to repeat it. Sometimes just breaking the fibers there, stretching with the balloon, does give them quite a long-last effect. We've had some study just recently completed. We've sent it for publication. It was a medical student project. So hopefully we're going to see the outcome and the number of times that we do balloon dilate these patients after the first dilatation.
Does TNO have a role in Barrett's esophagus?
TNO should be actually the first line of management in surveillance for Barrett's esophagus, because you can, it's an examination that is easily done and morbidity is less. You can easily take a biopsy. I think one of the reasons why Barrett's is not being followed with surveillance is to do with the cost, because if all patients with Barrett's will have to come for an OGD, I don't think the NHS would cope with that. Although there are some studies showing that the risk is minimum, but we know that there are some that will turn out to be cancer. So this is why some of the Barrett's, they do follow them, say once a year or 2 yearly. But I think if every department will have their own TNO, especially in the ENT, we'll find that these patients with Barrett's will be screening them more often. And in my clinic, when I see Barrett's, I take a biopsy and then refer the patients to the gastroenterologist to do the rest.
Who in our trust also do TNOs.
Yeah.
Use air when you're balloon dilating instead of normal saline?
You can use air, but the manufacturer said to use the saline because if you use air, you're not going to get enough pressure to stretch. Based on the description, the 6 atmospheric pressure can only be attained if you have liquid in there.
Okay. Now,
so do not be afraid. Why would you look to use air? You're afraid of normal saline going into the stomach or the lungs. It's nothing there to worry about if it bursts. And again, I've done loads and hundreds of TNO. There's just one case that burst, and the patient didn't even feel anything at all.
Yeah. So if you do get a mucosal tear or you perforate and you put an NG tube in, as you said at the end, the mucosal tears, you don't tend to put in an NG tube. But if you did need to put an NG tube in for a patient with a larger perforation, how long would you keep it in?
So I'll keep it for at least a week, and then I'll do a contrast swallow to check the size of the perforation. So if I suspect I have a perforation, within 24 hours, I'll do a contrast swallow just to check to be sure whether it is the case. And if there is truly a perforation there, nail by mouth, antibiotics, nasogastric tube, and then I'll repeat it in a week time again. And if it seals, then I'll take the tube out and then feed the patient. Because you remember with the OPA GI surgeons, they do anastomosis. So they'll have lots of perforations around the area. They put the nasogastric tube. Sometimes they feed the patient after 5 days, actually, as well. And sometimes they say, actually, early feeding this patient will probably enhance with the healing. But I would wait for 7 days and then do another contrast swallow. Not the barium swallow, a contrast swallow, just at least if there's any leak, it doesn't go into the mediastinum.
Perfect. Now, we're reaching 8 o'clock, so there's just 2 very short questions here. Someone's asked if there were white patches here and there in the hypopharynx, do you think they should get antifungals?
Yes. Yeah. I think if I see any white patches there, almost invariably it will be thrush.
And then finally, what's your standard local anesthetic protocol for a TNO?
The standard local anesthetic is to spray the nasal cavities, each side with 5 puffs of 5% lidocaine with phenylephrine. It numbs the nose and it dilates it as well. And also the reason I do both nostrils because sometimes you're not sure which side is going to be more patent. And I also use 10% xylocaine oral spray into the pharynx. I will spray the epiglottis and then I will spray the vocal cord as well because sometimes if you're doing balloon dilatation, when you touch the epiglottis, the patient will be choking.
Perfect. Well, thank you all for joining. Thank you, Mr. Karagana.
That's brilliant. We had 80 participants there. That's great. Absolutely.
Absolutely. I think it was over 80. Yeah, absolutely amazing. Yeah. One last question. I want to make sure that is answered. How can you spray the epiglottis? 2 ways.
Yeah. There are so many ways you can spray the epiglottis. The easiest way is to hold the patient tongue. So spray the soft palate first. And then the nozzle on the spray, you bend it by 90 degrees, and then you have an assistant showing you the epiglottis, and then you can spray directly onto the epiglottis or into the vocal cords. Or you can use what we call mucosal atomization device. It's just like a cannula, like a catheter. You can see it. You may find it in your anesthetic room, and then you bend it slightly by 90 degrees, or maybe even a curved suction if you don't have this fancy gadget. Or you can put it through the TNO channel, but there's lots of dead space in the TNO channel, so you may need to use epidural catheter and then pass it through the channel, and then you put some droplets there. So there are so many ways that you can do that.
Brilliant. Well, that does end it. You've literally covered everything. Thank you so much, everyone, for joining. Thank you very much, Mr. Karagama, for introducing us to all the endoscopic applications of the TNO. for beautifully demonstrating it with all your lovely videos, for helping us with the wider management of dysphagia under general anaesthetic, for showing us the importance of swallowing for quality of life, and demonstrating how valuable a knowledge of dysphagia is and how to manage it to complete one's own laryngology training. Thank you everyone for joining. This has been Mr. Karagama talking about endoscopic management of dysphagia. Please do join us